Nurse Theorists, Portraits of Excellence. In this edition, we feature Sister Callista Roy.
I was born in Los Angeles, California, actually at the county hospital. I was the second child. My mother was 20 when I was born. I eventually had 7 brothers and 6 sisters, so that's 7 and 7. I was the oldest girl, and I have a brother just older. And then we go boy, girl down the line, almost all the way. I think my parents had an unusual ability to cope with life as it came, and an intense faith, just a very deep and beautiful faith. My dad was a punch press operator, and often he did heavy manual work during the day, and he often worked evenings at maintenance jobs to keep a living for the family. My mother was a vocational nurse. I was 8 years old when my mother started working, and she started as an aide and then gradually started taking evening classes and earned her vocational nursing license. And at one point she didn't have enough hours in communicable diseases, so they added up all the chickenpox and measles and whooping cough that we had, and my mother had the hours for her communicable disease rotation of the program. I went to parochial schools all through grade school and went straight into Bishop Connedy Girls High School. My high school years, I got into everything. I led very much the life of a quite normal teenager. I was active in some in sports, more in, I tried acting, I did some music, I played in the school orchestra, both the violin, and then later the bass viol. I went to all the school dances. One person I went steady with for 3 years. Because I was at the same time dealing with the decision of whether or not to enter the religious community, I had decided not to take him to the senior prom, and which was very hard. Nice fellow, wonderful fellow, and I feel most grateful, that I had such a, really normal life of a kid. Again, carrying responsibilities of home. Also, simultaneously with going to high school, I started my first job in the hospital. At the end of my freshman year, my mother had gone to, who was then working at a hospital in Los Angeles, one of the then very large hospitals, asked to one of the supervisors, how old would my daughter have to be to work here? She said, have her come on Saturday. So I started at age 14. And my first promotion was to maid. So before that, I was a pantry girl. So I was not a nurse's aide for a couple of years. Right after high school, I entered the Sisters of St. Joseph of Carondelet. I had been trying to decide, number one, whether to enter religious life. I was also very interested in becoming a nurse. One of the nurses at the hospital, Ms. Flora Hasegawa, had advised me to be sure and get a baccalaureate degree. Now, again, we're talking about the mid to late 1950s, and I was very grateful that that was planted in my head early on, that I should get a baccalaureate degree. So I had applied to Mount St. Mary's College, got a 4-year scholarship, so that it would have been possible for me to go, but at the same time decided to enter community. I started my general ed courses at college and then didn't choose the major until after I made my first vows. And at that time, it really is a decision of the community what kind of works need to be done. At least at that time it was. And I was still trying to decide, would I in community be of more service as a teacher, recognizing my own good education at both the grammar school and high school level. And or did I still want to be a nurse? Well, at the very end, as it became decision time, I very much wanted to go into the nursing program, and in fact did. I got my bachelor's degree at Mount St. Mary's in 1963, and then I did staff nursing at St. Mary's Hospital in Tucson, Arizona, and worked mainly in pediatrics. So the following year, then I started my master's degree at UCLA and had the wonderful opportunity of studying with Dorothy Johnson for the next couple of years. So I was a year and a half in the master's program, and then after that went as an acting director of nursing and nursing consultant to our own hospital up in Lewiston, Idaho. That also was a very good experience because, again, very quickly I took a lot of responsibility. And then following that, because I had really been prepared to teach at our college, Mount St. Mary's, went there. After a total of 17 years at Mount St. Mary's with time off for education and one sabbatical and being back at Mount St. Mary's, and then I was finally back in the position of scholar in residence the last year or two that I was there. I then applied for the very first of the postdoctoral fellows funded by the Robert Wood Johnson Foundation and was fortunate to be awarded one of those very first awards. And I had selected San Francisco as my site not because of the city in California, but rather the strength in the neurosciences there. And it became very clear to me that I really wanted a postdoc. I wanted it in nursing, and I saw the field of neurosciences as the whole new frontier.
I think I've known her 6 or 8 years now. I first knew Dr. Roy when she came to the University of California, San Francisco to do a postdoctoral fellowship. And she came to study with me at that time. And she was an amazing scholar and academician, energetic and goal-directed, outstanding scholar. I think the major impact on nursing from her having been a Robert Wood Johnson scholar is that she made it visible, that a postdoctoral fellowship then came to be valued by nursing. Now nurses are beginning to see, those who want to continue in academic life and be researchers are seeing it quite important to serve a postdoctoral fellowship. The thing about Callista, I think that strikes me most is that she believes in the basic human good of people and values that. She's the most just individual I think I've ever known.
Dr. Roy discussed her adaptation model with Dr. Jacqueline Fawcett on the Boston College campus in the John Francis Room of the John J. Burns Library.
Callista, I'd like to thank you so very much for agreeing to do this interview. It's really an honor for me to have the opportunity to talk to you today.
I'm very happy to be here.
I'd like to start by asking you to tell us a little bit more about your philosophic and scientific assumptions. I know you've written about them, but I wonder if you could tell us a little bit more about them.
In the development of the philosophical assumptions and the scientific assumptions, they don't all develop at once. It's a very evolving process, and I think it's important to understand too that they, in my own beliefs, have not changed, but that the articulation of them at different points of time differs and grows. And for different needs, I find it important to articulate different things at different points in time. We actually began with the scientific assumptions because, as Dorothy Johnson said, to get into advanced clinical content in pediatric nursing, we must clearly describe what our view of nursing is. So I naively say, oh, I believe it's promoting patient adaptation. She said, what do you mean by that? So I then must clearly articulate what do we, on what science can I base some beliefs about what adaptation is about if I really believe that that's what nursing is about. So early on, I became involved in looking at it from a systems theory approach, again, from my heritage with Dorothy Johnson. And seeing systems as working as a whole, have parts that are integrated, which function toward an end, which I felt was very useful in conceptualizing individuals, groups, social systems, the ecology, etc. By the same token, then, as I was really pushed to get a definition of adaptation, I hit upon the work of Harry Helson, whose book came out in 1964, the year I was beginning this work. And because it began with A, I found it in the card catalog, is how I originally, as often happens in discovering and moving on with learning. And there I saw a lot of concepts described which I felt very nicely would transfer to give a basis for what I could build in nursing. And I must say, as through the years I go back to some of that early work and also deepen my own understanding of both the applications of the concepts as well as the articulation of what the core concept is, adaptation, I find the foundational work by Helson not only still applicable but entirely true and relevant. Although I have certainly moved that concept beyond and developed it further. So start out with some of those basic notions and assumptions. Helson's work being the idea that adaptation is a function of what's coming into the person and then what they have to deal with it, focal, contextual, residual stimuli. Now, the second part of your question has to do with the philosophical. And I think as nursing has evolved its own heritage and beliefs, humanism expresses well some of our beliefs about the individual and the worth of the individual, about the creativity of the individual, about the interpersonal relations within the individual, which are emphasized in some of the other theoretical approaches. And still I felt there was something missing. And so I was kind of trying to articulate what that was for me. And the key I found when I was at the Rogers Conference in 1983 in New York, and one of the speakers mentioned relativism as basic. And I said, aha, that's the key for me, because I know that that is not my philosophical stance. So then the next few years were then trying to articulate better than what is not the opposite of relativism. And so there I began to think more about the individual in society. And actually it was in that era where I received an honorary doctorate with U.S. Surgeon General Koop. And so we were talking about the lot of needs of society and individuals in society, et cetera, of which he has been much more vocal more recently. However, then I began to try to put together those philosophical assumptions. And at that point then I coined a term, veritivity, meaning truth that is one, because in addition to the purposefulness of an individual's actions, as humanism would hold, and the importance of that, then I also look to the purposefulness of human nature, and the purposefulness then of human existence, and the value of life in general, and the individual in society. You see, so if you add those values to it, then I think you do have a different basis. And then I think you can read my works from a different perspective. I was surprised that people were reading my work as very behavioristic or only, and other sorts of views, because seeing it as mechanistic, because it used the word stimuli, stimulus response or whatever, response patterns or whatever. So it's been important to me then to have the opportunity to articulate these more clearly, think them through myself, and to say them.
I wonder if you could tell us what your current thinking about the Roy adaptation model is and what you're planning for the model.
The current work on the model is on several levels. One direction would be in moving it from the individual person level to the group level. There's a significant amount of work going on there, as I co-authored one paper with a person who has an administration background and research in administration to show the adaptive system of the nursing or administration within a healthcare institution, and that being a wide frontier for all kinds of needs and work, that ways to solve problems of adaptation there, and kind of reconstructing the adaptive system so that it's not just a transfer of the individual model, but rather a transformation of it. What is an adaptive system at the group level, and then what are the mechanisms and ends for that? And so I think that work, because there are a lot of people who have needs in that area, should and can be developed now with people with expertise. So we've put some groundwork out there in the literature on that. I think another major area for me is I do see models and theories as different. And it's as if I sort of get the question sometimes, when is your model going to grow up and be a theory? Well, they don't. You know, I think they're two separate things. And models serve their purpose by leading to theory development, education, curricular patterns, and research. but they stay models, and then at the same time the theory work is going on. I've done a lot of theoretical development on the adaptive modes, as in the Roy and Roberts text, where we develop many propositions and hypotheses. The work in my postdoctoral fellow at the University of California at San Francisco was in the neurosciences, and that was very purposeful in that I felt the need to do a postdoc in nursing, and the neurosciences specifically because of that integration of the person, what at the broadest level, body, mind, or cognitor regulator is what it is for me. So, and that has just opened a whole new world that has just been terribly exciting. And it was the similar experience studying with Dr. Connie Robinson there as it was studying with Dorothy Johnson at the master's level. So now I expect and will continue with an era of clinical research in the neurosciences, but it is not for the sake of the neurosciences, which I hope to make a contribution to clinically, but at the same time to knowledge development, because it's the integration of the person. When you see the incredible, construction of the nervous system and how it interacts, and then how people use who they are totally within that as a regulating, thinking, feeling being. And that's what nursing is about, is using that for the person's best advantage to adapt. And so therefore, my purpose then would be to develop the theories and knowledge related to cognitor regulator activity. And I think then that will we'll have a lot of the middle range theories that relate to effective nursing practice. And some of it will be with specific patient populations. I work right now with the minor head injury patients.
You've already talked about how the model can be used in administration, how the adaptive system can be thought of as an institution or a clinical agency. I wonder if you could tell us now how the model is used in education, how it can be used as a guide for the curriculum.
I think the curriculum work on the model, of course, was what gave it its great impetus in the beginning. And the timeliness of being in a small institution on the West Coast, the traditions were very young. The administration was Sister Rebecca Doan was the chair of the department at the time, and very eager to support new ideas and to give me the time and the freedom to do it. The first year out of my, or second year out of my master's program, to be implementing a new curriculum based on new ideas with absolutely no literature in the field with 10, 12 faculty was very exciting. And I think that but it was actually the stimulus that kept the model growth going, in addition to a lot of other professional commitments, and Dorothy Johnson inviting me to come speak and to her class, and probably the first models class that was ever taught, and saying, now please indicate its implications for education, practice, and research. The graduate level, I think it's had a great impact. At the master's level, it's been the entree to improving practice, because you get people in leadership positions in hospitals and healthcare agencies coming to get their master's degrees, really being turned on to the idea that nursing does have a specific place and role and can work very collaborative with medicine by that contribution that only they can make. And then at that point, then I think it makes a real impact on practice. So I think the master's curriculums have definitely been widely influenced by models in general and by the Roy model in particular.
It would seem at the doctoral level that the Roy adaptation model would be very helpful to guide student dissertation research. I wonder if you could tell us what you know about dissertation research as well as other research that's been based on the model, and whether you see that this research is beginning to develop into a cohesive body of nursing knowledge.
The implications for research, I think, are probably the most important piece of the model, and at this point, one of the areas of keen development. And probably my higher commitment is to knowledge development in nursing. Now, the vehicle then is through a given model. And I think it is important, my, again, early commitment and belief from my mentor, Dorothy Johnson, to take a given focus and work systematically with it, I still hold in terms of my own work. I don't necessarily believe that at this point in time we need to do that for the profession. I think there are some levels of unity at a higher level of common beliefs of the discipline, and then a few approaches at this time that we need to play out, if you will, to their maximum development in knowledge development, and perhaps some structure for knowledge will come from that that is overall for the discipline. In the meantime, I think it is important that we do our job, those of us who work with the Roy model, to continue to develop the research in that area. And as best as I can tell, there are well over 100 articles in the literature that we have been able to get in general. There's a recent article in a library science magazine that shows that by current techniques you will miss 75% of all articles, and showing how to retrieve better. So hopefully we'll be able to get better accounts even of how many there are. But of the 100 in the literature, an increasing percent of them are research-based.
In your contacts with and observations of nurses who are using the Roy adaptation model, what conclusions have you been able to draw about how the model has helped nurses to think about nursing?
I think that a real strength of the model and contribution that it has made has been exactly that nurses do have a different perspective on nursing after studying the model. And in the very beginning, I taught registered nurses coming back to school, and their eyes were open. In 6 weeks, they were just so excited about what nursing was about. And that remains true to this day, similar experiences of people who teach it. New students, I had to interview them for a videotape because it was I began getting calls for consultation. That first article went out, I had my first call for consultation, and our first class was being entered, so we're 2 weeks into the semester or whatever. I do a video to interview these students to carry with me. Actually, it was by then a little farther into the semester, and they said, well, we were talking about that over in the dorms, and we don't know how it could be any other way. Just totally. Their thinking is entirely in that mode. When we brought our graduates back, after two years, we brought back the first class and had them talk to the other classes and then dialogue. And they were saying, when they first get out, they don't think a whole lot about it. And pretty soon they feel real guilty and they think, my gosh, what am I doing with this wonderful education that I had? Then they think, it has influenced the whole way I think anyway. And they realize that everything they do is out of that mode. And similarly, myself, going into an ICU, being assigned a multi-system failure patient, critically ill, I couldn't begin my job, this is as a postdoc clinical nurse scholar, unless I had a framework for quickly organizing what to do. And you just tick off the adaptive modes, you put them in some order of priority according to the goals of adaptation, survival, and et cetera, and you set to work. It does, and it also gives nurses a real sense of pride in what they contribute to nursing, and then their contribution to the healthcare team as a whole.
How do you see that adaptation nursing, using the Roy adaptation model, differentiates nursing from medicine?
I think it has to do with the goal of the activity. The goal is to promote adaptation, and the activity then has to do with managing focal contextual stimuli. Medicine, and that's its very generic terms. What that means is it promoting, now it doesn't mean that the physician doesn't deal with survival. It's an awful lot of what the physician deals with. But if you take the whole of it, survival, growth, reproduction, and mastery all at once. And again, as a philosopher of science said, nursing chooses the whole thing, you can study a cell, but we take people who are made up of cells whose potential, is infinity, and we take the whole thing. But that is our mission. So then the ends for which we operate then are one thing, and medicines is different. It's to heal and to cure disease. Well, those definitions are totally different. Then you take, and how do you go about it? Medicine has certain techniques of diagnosis, medical diagnosis of disease, and certain medical treatments. Now, we are often in settings where patients are receiving those treatments and diagnostic workups, etc., and are often involved in those activities, which those patients are dealing with as whole people. I think it is entirely appropriate that the nurse be a part of that, and entirely appropriate that he or she know a great deal about the entire person and every cell in the body and how it works, because it is the whole person.
Another question I'd like to ask has to do with the settings and client populations for which a conceptual model is appropriate. So I'd like to know if you think that the Roy adaptation model is not appropriate in certain situations and for certain clients' populations.
I have not yet found one, and I don't know anyone who has. I can remember early on, as we were doing some initial curriculum work, and as any group makes a change, someone saying, it doesn't apply here. And the next person coming along say, the very best place to apply it, for example, is psych. And someone else, so I think it has to do with the understanding of the model. And also, if you go back to the basic beliefs, if in fact you accept and understand that people can be conceptualized as adaptive systems, and this helps us understand and predict and explain, then it follows that it will apply, because people won't change, you see, from system to system. And you have to better understand the environments that they're in. You have to better understand how adaptive systems work. But no, I don't think we will find one that it doesn't, because I do believe the basic premises are sound.
Callista, you have made many contributions in the form of published articles, books, and many presentations throughout the world. I wonder, though, what contribution is most important to you?
I think my major contribution is yet to come. I, of course, have been very gratified and excited about the work as it has developed through the years, and totally unpremeditated, if you will. I just follow what needs to be done next with it, and with everything that I do. What I believe needs to be done, I do. It's important to me to grow as scholar in the field of the neurosciences, and then with that we'll continue to grow what I am able to contribute. And then I think, too, the contribution will be a piece of what nursing knowledge is about. And I think all of us are working in that direction. And I think this is just a terribly exciting, productive, critical time. I think a lot of the groundwork has been laid. And I think the work of the American Academy of Nursing in knowledge development for the year 2000 was key to me. It took a lot of time to get even that one scientific program session. And I think we will go from there on and continue to do things that make nursing a key discipline in healthcare and in the professions and in the world as a whole. And I think that is what will happen, and I think I will make a contribution to that.
Where do you see yourself in the future, Callista? What work do you have planned for the next several years?
I think in the immediate future and throughout my career, I will remain focused on knowledge development in nursing. And I think the particular timing of working with a new doctoral program here at Boston College is very exciting. and we have very knowledgeable and eager students, and it is parallel again to the experience of starting a baccalaureate program on a model-based curriculum when that was new. And I think the level of knowledge development that we're at now and the people that I work with, this can be a very exciting time for that work. And as with everything, I have done, as I said, what I think needs to be done, and will do that as long as that I feel that it is moving toward that overall feeding into the future of nursing. The clinical research piece is extremely important to me, and so I've worked very hard in trying to transfer that work from the San Francisco area to the Boston area. And it takes some doing in the complicated healthcare systems here, but I will continue to work with that. I enjoy very much the international contacts, but of course all of this it takes a lot of energy. I have a lot of energy, but have had health problems, and I had a successful surgery with an acoustic neuroma removal 10 years ago with just some residual damage, but now have to deal day to day with some ongoing problems, and particularly trying to regulate some partial seizure activity. So it's up to me to then balance where I see the priorities, the needs, and mostly to foster other people also picking up, being excited about, and continuing to contribute in the same positive way.
So what you're saying then is that you'll be able to continue your work, but given your current health status, that you have to set some priorities.
I need the flexibility to manage, adapt between what's going on in my internal environment with the demands from the external environment.
Nicely said in terms of the Roy model. Would you tell us, Callista, what has given you the most satisfaction in your nursing career to date?
You know, interestingly enough, I really think it is seeing other people grow. When a nurse who has been discouraged finds some new hope, when a faculty member calls me, when I've sent her to do a consultation visit on the Roy model, and she says, "Do you know, I was the expert," when people do their first publications. And I think I have never had a problem with copywriting my material, et cetera, and I think that that has contributed to the spirit of its growth, because I tell people, take what's useful. You know, if it helps, fine. If you change it, fine. Just identify that you have. And if we want to study what of the model is working, then identify that how you're using it, you see. But that's a different matter. But that it has helped, that it has helped patients, that it has helped nurses, that it, I guess that means a lot to me. And it means a lot to me to be a practicing adaptation nurse.
In closing, I'd like to once again thank you very much for agreeing to do this interview. It's been very informative, very interesting. And I'd like to wish you very well in the future.
This is a unique privilege to have the opportunity to speak with those who are interested in this very particular time in our development, and I thank all those involved, and you particularly, Jackie, for coming to Boston College today.
My family shares a lot of pride in Callista's accomplishments over the years, and it grows as the list of accomplishments and honors grow. We really do respect what she does. We understand its impact. Callista and I really became friends as adults. There's a gap in age between us. She was the second and I was the eighth. And in addition, she had left for the convent when I was still quite young. But we came to know each other quite closely as friends, as adults. I think that Callista has tried to bring to the field of nursing, within herself as a person and within herself as a representative of the field of nursing, the idea that the commitment, the values, the reasons that one does one's professional services should drive the selections of the services you do and should drive the way you deliver those services. It is not necessarily easy in this world to talk about ethics and values driving one's professional life, driving one's area of professional expertise and services. And I would hope that people would begin to explore with her what using their personal values and their personal ethics to look at their own personal lives and professional lives will become an important part of the skills and the knowledge that she brings to the field of nursing. And I believe she embodies that very essence of having one's ethics and one's values drive her professional life.